So the first part that I'm going to go over is going to be supraventricular arrhythmias. And I know I didn't really define what arrhythmia is yet, but for now, just think of it as crazy electrical disturbances. So think of it that way first. So before I start, you divide your arrhythmias into two parts, all right? So the first part is I'm going to draw a heart over here. And then the first part concerns the top part of the heart. So the top part of the heart is your atria is on the top. You know the atria is on the top, and it's separated electrically by this fibrous area over here. This is called the annulus fibrosus cordis. And it prevents all types of electrical inputs from the top going to the bottom. The way that your SA node is able to send your information down to your ventricles is going to be based on only your AV node. So what you have is you have your SA node coming down to your AV node. Your AV node is then going to have your right and left bundle branch blocks, and then it's going to go for the rest of the ventricles. So number one concept that you have to know is that the most important part of your heart is the atria or the ventricles. Ventricles. You see, the atria is not that important. So your atria, you can technically live practically with your atria going haywire the whole entire time. People live with atrial fibrillation for like years. I've seen a patient that has, in my rotation recently, that had atrial fib for the last 10 years. They have to use warfarin to make sure that they don't make a mural thrombus or anything like that. But overall, you can live with crazy electrical disturbances in your atria. But the problem is, if you have crazy things going in from your atria, it's going to go to your AV node. If it goes to your AV node, it's going to send signals, and then it's going to make your ventricles beat faster. If you do this constantly and you keep on harassing your ventricles over and over again, you can develop a VTAC. And that's the worst thing you want to do. So your goal of treatment for anything above the ventricles is to stop the signals from going to your ventricles. So the idea is your role of treatment is to slow the conduction down. Protect your ventricles. So that's the one thing you need to know. So the first thing you need to know is that the goal of your treatment is to protect ventricles. So I'm going to just draw like, this is like your ventricle space and just minor treat. Okay, so how do you slow that conduction down? So what we're talking about right now is we were talking about specifically the AV node. So the AV node, would you consider the AV, okay, so I'm going to separate this into two parts, okay? Drugs that affect nodes, like the SA node and the AV node, and then drugs that affect the muscle. You need to be able to separate drugs that affect nodes and drugs that affect muscle. So you guys already got introduced like to your class 1, 2, 3, 4 drugs, right? Okay, so I'm going to make it easy for you guys. I'm going to make a cheat sheet off to the side of my page over here, and then I want you to refer to it if you ever forget what class 1 or class 2, but I'm going to make it so that hopefully in like 5 seconds you would be able to recall it. Oh crap, that's not the right one. And be able to name them if this would actually work. Wait, I think I can't touch it. Oh no. Okay, got it. I'm a little too antsy. I'm actually double tapping things. Okay, so you know that you have several types of antiarrhythmics. So I'm just going to name them, okay? So the first type of antiarrhythmic you have is sodium. I'm going to just name it sodium. The next one is beta blockers. The next one you have is potassium. And the last one you have calcium. You're all blockers. So the way that I remember this, I made a mnemonic for this. It's some bros pass cardiology. And coincidentally, this is going to be class 1, class 2, class 3, class 4 drugs. Okay? So, I mean, for the most part, throughout the rest of the lecture, I'm going to be talking to them specifically in terms of like, oh, it's a sodium channel blocker and a potassium channel blocker. I'm going to talk to you in that way. So that's the first thing you need to know. Just remember, some bros pass cardiology, you know the classes, because they'll always ask you the classes and stuff like that. But here's the thing. There's only one thing that I really need you to memorize, and it's not really written anywhere, but if you memorize it, it makes things a lot easier, okay? So that's why I made the cheat sheet, because no one actually shows it this way. First thing is that some drugs affect the myocytes. And then some drugs will affect the nodes. You know that they're different tissue, right? The nodes are, they kind of self-make their action potential, but the myocytes just kind of sit there and get excited about other things. Well, these drugs affect, some of them affect myocytes. Some of them affect nodes. So the two drugs that affect myocytes are going to be sodium channels blockers and potassium channel blockers. And then the drugs that affect the nodes are going to be your beta blockers. And I'll explain these too. I'm going to explain exactly why they work on these things. But just having one piece of information to lead you to so many things is just really powerful and it's really useful. So those three are nodal drugs. They affect the nodes. They affect other things too, but not in terms of arrhythmias, like beta blockers. Okay, so when we talk about beta blockers first. So what I was talking about before was I was talking about what is the most important part of the heart? Ventricles. You want to protect the ventricles if something crazy is going on, some electrical disturbance is happening on top. So let's slow down the AV node. How do you slow down the AV node? Ideas? Okay, just think of it in a really easy way. Like physiologically, how do you slow the AV node? I mean, parasympathetic. Parasympathetic is a good one. How about, what speeds it up? Sympathetic. Okay, so let's think about that first. So how do we make the AV node go faster? Sympathetic, beta 1. If we make it go faster, if you have crazy activity going from the atria, going down to your AV node, do you think a faster AV conduction will help your ventricles? No. Beta blocker. Okay, so let's talk about these beta blockers. So I'm going to draw this over here. This is time over here, and this is going to be your millivolts. Nodal tissue. How does nodal tissue look like? It looks like this. Right? So let's name the channels, and the channels are kind of important. So I'm going to do this from here to here. I'm talking about this segment over here. What channel is there? Sodium funnies. Okay, this is sodium funny. Okay, what's the next one? What's this one over here? There's two of them, right? Just think of them like calcium right here. So remember, the SA node and the AV node don't work on any sort of sodium channels, which makes sense. what did I say about one class 1 drugs for sodium channels? Do they affect the nodes? No. Why? There's no sodium channels here. That's calcium. So, calcium. Next thing, how do you repolarize it? Potassium. What potassium are these? They're just like the IK channels. Not K1 channels. K1 is the one that keep the membrane potential. So those are our channels. Okay, so let's use this. Let's use this over here. I'm just going to make a copy of it because that's like your baseline, because I'm going to be playing with your baseline. And then I'm going to be putting over here. Don't go away. Come back. Okay, so beta blockers. Where do beta blockers work on? They work on the funny channels. So the funny channels is this blue one over here on the bottom. So what beta blockers do, what does beta do? Beta makes it shorter. Beta makes it depolarize faster, so you would be able to depolarize faster. That's a beta agonist. But if a beta blocker would slow it down, right? So if it slows down, then it will take longer time to get to its action potential threshold. So look at that gray line. The gray line took a lot longer to get there, all right? So I'm going to draw the rest of it, and let's compare the start points of the normal. Let's take a look at the normal. The normal is this highlighted one over here, okay? And then this new one that goes over here. In terms of how fast the heart beats in those instances, which one's longer? The beta, the regular one, or the beta blocked one? Beta blocked one. So it slows it down. When you slow it down, if you have crazy activity in your atria and it's going down, and then now you slow down the AV node, do you protect your ventricles? Yes. So that's why beta blockers will help you treat any supraventricular problem in terms of arrhythmias. Okay? So that's beta blockers. As you can imagine, there's some other channels here. You have like the funny channel, you have the calcium channel, you have the potassium channel. Well, let's go over the next one. Let's go over calcium channels. Okay? So I'm going to be taking the same exact one as a template. Like this. And I'm just going to talk about the calcium channels. So the calcium channels are affected by calcium channel blockers. So let's take a look at this. So from the funny channel, are the funny channels affected by the calcium channel blockers? No, they're sodium channels. So that's not going to change anything. But calcium, if you slow it down, how will it look like? It would take longer to reach the same exact threshold. And if you want to use the boxes that I have over here, you can notice that like this over here, this is like one box before it reaches threshold, and it takes 2 boxes to reach threshold. It's slower. If it's slower and everything else is the same, what do you notice about how fast your heart rate goes? It goes slower. So if it goes slower, are you protecting the ventricles? Yes, you are. Okay. So that's your calcium channel blockers. Alrighty? So the last one. There's only one more channel left, right? So there's 3 channels. We're going to affect the potassium channels. Now the potassium channels are interesting. Let's refer back to our cheat sheet. So in our cheat sheets, we said that potassium channels will affect both the myocytes and the nodes. It's one of those exceptions. It's very unique to potassium channels because both the nodal tissues and the myocytes have the same exact potassium channel. And this is the only time that the 2 drugs actually overlap, that they actually affect both tissue. So the potassium ones, I'm going to draw it over here. Can you imagine how it go? I mean, if you're drawing it right now with yourself, try to figure out how the potassium would be. Sodium wouldn't change, calcium wouldn't change, potassium, it has to repolarize the cell. It will take longer. Heart rate, does it go faster or slower? Slower. Do you protect the ventricles? You protect the ventricles. All supraventricular drugs, all supraventricular arrhythmias can be treated technically by these 3 classes of drugs. So if you have anything going crazy, block the AV node. This is actually considered a first-degree block. What you're actually doing, you're inducing a first-degree block. That way you can protect the ventricles. Got it so far? If a patient has atrial fibrillation, what can you use? Bros past cardiology. You can use all of them, technically. Atrial flutter, what can you use? Bros past cardiology. Beta blockers, potassium channels, calcium channel blockers. Sinus tachycardia. You can use the same stuff, but if it's a sinus tachycardia, technically you don't want to use potassium channel blockers because they affect the monocytes too. And sinus tachycardia is just the muscle itself, right? I know it's node itself. Sinus tachycardia is your SA node. It's going crazy. It's sending 2 main signals to your AV node. It's not really a muscle problem. So technically, it would be better to just use a beta blocker, a calcium channel blocker. That's a really minutiae thing, but just think of supraventricular and ventricular. Think of it that way. Okay, so we talked about the sympathetic parts. We talked about these other channels going in between, and let's go over some really important drugs that they use outside of the classes that they have here. First thing is that you can actually create a block on your AV node without any drugs at all. How can you do that? Well, the way that people do it is by massaging the carotid sinus. Because if you massage a carotid sinus, what does your carotid sinus do? It does pressure. It's a pressure sensor. So if you're poking at it, and then your carotid sinus is like crap, the pressure is so high. What do you do? What does the body do? You're going to slow it down. How? Vagal stimulation. Vagal stimulation is muscarinic. What chunk is the muscarinic that have? Because remember, the flight channels are going to be the sympathetic and the parasympathetic channel. It affects both of them. So if you want to if someone has atrial fibrillation, here's a really quick thing. Like if the person has atrial fib and then you don't have any drugs on you, you could give them a carotid massage, and it should slow down their AV node enough so that it will protect the ventricles. Of course, it's not really a long-term type of use for long term. That's not very good, but it does get tested, so you should know that one. Okay, so. The next one, I'm just going to write it in your notes so that when I post it up, you'll have everything. So carotid massage will make it think that you have high pressure, right? And then that will make increased vagal stimulation. And then that would decrease the conduction of the AV node. All right, one more drug. The other drug that they typically use is this drug called adenosine. And I know that what you're thinking is like, crap, adenosine. I don't like this drug because it's confusing. But I have a trick. When I say adenosine, you say muscarinic. Adenosine? Okay, so what did I just say about muscarinic before? Muscarinic does the fine channels. It slows things down. Slows things down and protects the ventricles. So adenosine will induce a heart block. It's a heart block medication. it will give you a heart block. I mean, albeit it only gives it a heart block for like 10 seconds, but sometimes it will stop the arrhythmias enough that you can like cardiovert them. Cardiovert is like shocking them afterwards. But adenosine is a heart block. But what you should be thinking when you see adenosine is you want to be thinking muscarinic. And when I say muscarinic, you can think about all the side effects of muscarinic. So one of the major side effects of adenosine is going to be they're going to feel like they have an elephant on top of their chest. Why do you think that they feel that way? What does muscarinic effect have on your bronchioles? Bronchoconstriction or bronchodilation? Bronchoconstriction. So are you going to give adenosine to a patient that has asthma? No, not really. So one of the big side effects of this is going to be this. Yeah. It's a really big side effect. You should definitely tell your patients that I'm going to give you this drug. You're going to feel this elephant on top of your chest. It's normal. Be careful when giving this to asthmatic patients. Okay, does everyone understand that part first? Supraventricular versus everything else. I'm going to talk about everything else. You have any questions?